Hospice. Hospice is about the only place where you can do that. Now, did you hear the question? The question, the statement was that you learn this as a nurse. You learn all of these things as a nurse, but then where can you practice it? And my response was hospice. Hospice does this, and that's where I've learned this. My practice of medicine has changed totally since I was a nephrologist. And as a nephrologist, I was open to this, but I could not do it as well as I can now. And not that I do it well. But, and the other thing is too, depending on where you're working, in medical, physician stuff doesn't get this yet. And I'm hoping that it will, but who knows?
I keep a job because I want to work like this.
I know. I know.
I live in Billings and I'm unemployed by choice.
Yeah.
How do you address it with patients? I find this especially with elderly that have been prescribed narcotics. They are to take. They have real pain, but they don't want to take it. They're reluctant to take it. I don't want to get addicted.
Okay. The question is, and I will paraphrase this, is that the elderly are given narcotics because they have significant pain. However, they don't want to take it because they don't want to become addicted. Part of that is, most of that is education, not only of the patient, the elderly, their family, and their healthcare providers. There is a difference between addiction and tolerance. And I think most of you probably know that. Addiction, it does not happen with everybody taking narcotics. It doesn't happen with everybody who drinks alcohol. It doesn't happen with everybody who smokes, but most of them. Nicotine is a totally different drug than alcohol and narcotics. Nicotine it's like cocaine. You become addicted very quickly. So you have to and you try to get people to understand, and it's primarily the families, I think, are very important, because I've faced it many times. They don't want their loved one on narcotics because they'll become addicted. These are people who are dying. Come on. So, but it is, and people will develop a tolerance where they may require more medication. The way I try to explain it is this: if you are trying to get a buzz off of it, or you feel the high, that may lead you more towards addiction. If you're using it for treating pain and you're taking it as scheduled, the risk for addiction is less. It's when you start feeling that buzz and you want to get that buzz again, and that's when you're going to get more for addiction. That's my understanding of it.
But I think us as nurses, I'm finding too, because I'm really interested in pain management as well, because I think physicians don't know it as well as nurses do.
Physicians do not know pain management.
Well, I'm just saying that and their orders are going to be where you think every 6 hours. Are you kidding me? This guy can't get past 3 hours. And I had a physician once tell me, if you're truly treating pain, people don't become addicted to that. If you're treating their mood, then they could become addicted. But if you're truly treating pain, well, our problem is we're so judgmental. All of us co-workers don't work together well always, and it's like, well, she can't possibly be having that much pain. I don't think bingo. Right, she's at bingo. How could she be hurting? I don't think we should judge that. I mean, I don't think it's up to us to make that decision or that conclusion.
Did you hear that in the back? I'll paraphrase. The one comment is that it's not up to us to judge people when they're having pain. And somebody may be at bingo and still requesting a pain medication, or the other one I hear is that they're asleep, and therefore they should not be in pain. And so it's not up to us to judge when people need the pain medicine. And when people are treating the pain, they are usually not going to become addicted to the pain medicine. One of the other problems is that most physicians order their pain medicines every 6 hours, which we all know, and if you read it in the book, they don't last that long. And if anybody has ever been through surgery, they know how long that peak that medicine lasts. And so, but trying to get people to understand that is a tough part. and making sure they have adequate orders. Did I paraphrase it totally?
You did.
Okay. We have time for one more question.
I just wanted to make a statement about
I'll let you say it rather than me paraphrasing.
last
say it.
year I nearly died from MRSA, and I was given a 20% chance of living, and the pain I had, nobody understands your pain except for you. And I think if a nurse, and I've always been a nurse, that if I feel somebody has pain, I believe them totally. And you watch for it, and that's what you become a nurse for.
Yeah. And I think, once you've been through severe pain, you have a different perspective of it. The perception in those evaluation, those things to evaluate for pain, is a way of understanding people's pain. It may not, you can ask them and they say they're straight faced and they may not be in any pain. But, if you look at young girls, some of us are still young in the room, but menstrual cramps, you don't look like you're having menstrual cramps, do you? I mean, that's a classic example. If you looked and acted like you're in severe pain when you're going through your menses, half of us be in bed all the time. So, so I think that's a classic example. But understanding what people are going through is huge, and understanding of it. There are some people who are seeking drugs. Yes. Is it our responsibility to judge them? I don't know. And that's an individual thing, and you have to understand, but I think we need to understand all the different ramifications of pain and all the different ramifications of suffering and where they come from. And we are out of time, so you'll be able to go to the next speaker.